Good morning. Sorry again. We had to start all over again. Today's topic will be carpal tunnel syndrome, which is very relevant for you guys nowadays because most of you are online for academic and other activities, recreational activities also. And it has a relevance to today's topic. So all of you know that carpal tunnel syndrome has something to do with carpal bones. Carpal bones, as most of you know, are in the hand. So this is something to do with pain in the hand. Because of some inflammation in the tendons and tendon sheaths, the space which is available for this nerve is compromised. Then there are some symptoms present because of this insult. No nerve takes very kindly to any insult, so it will show some symptoms. So what are those symptoms? How do you diagnose? How do you manage? Is this class is all about. This condition is not new. This is not born with you guys. This is there for the last so many years. In fact, in 1984, Paget first described about this condition, and it's there since then. And day by day, I think now it's very, very common. And this is the commonest form of neuropathy. There are several neuropathies present in the body. Clinically, so many patients come to us with the different nerves being affected and so many neuropathies. But of all those things, carpal tunnel syndrome due to median nerve compression is the commonest form of neuropathy. See, by attending our class, even PG entrance preparation is also can be done simultaneously. So, lot of advantages for attending these classes, and because they are more active, it's more common in females because repetitive action of the hands is more commonly seen in females. So, this is also more common in females, and there are some other conditions which are unique to females, and in those clinical conditions also you will have this carpal tunnel syndrome. That's why this is more common in females. In short, this is called as CTS. CTS is carpal tunnel syndrome. And I told you that it is a repetitive stress, which is one of the reasons for this syndrome. Once you start doing the same motion again and again, because of the repetition, the soft tissues which are involved in that movement are stressed more and more, and the other soft tissues are not at all touched. So after certain point, then these soft tissues get injured, and they will have these deleterious effects. So this is a part of repetitive stress syndrome or injury, and these symptoms are due to inflammation of the tissues, which I have shown you in that slide. All the soft tissues which are around, and the ligament and the tenosynovium which covers the tendon, all of them get inflamed, and it will compress the median nerve because the space around nerve is compromised, and it's more or less a fibro-osseous tunnel, and it has nowhere to go. So once nerve is caught unguarded and by compressed from all sides, definitely it will show some symptoms. Because of this compression, the transmission of impulses in the nerve will come down, which can be clinically known, and in the laboratory also we can show that the nerve transmission has come down. And the patient, on their part, they will have pain and numbness and tingling in the wrist. Altered sensory symptoms will be there because compression of some of the fibers, sensory fibers, will lead to this numbness and tingling in the wrist, fingers, and hand. Except little finger. Why a little finger is spared? Because that is supplied by the ulnar nerve. Coming to the three important nerves which are present in the upper limb, if you can carefully see, this is the median nerve which comes out from the brachial plexus, and this is the ulnar nerve which is on the medial side. That's why radial little finger is spared in carpal tunnel syndrome. And radial nerve, all of you know, it It lies posteriorly and comes to lie. It posteriorly comes to lie on the lateral aspect, and which is in close association with the shaft of the humerus. And in most of the humeral shaft fractures, it is the radial nerve which get injured in the spiral groove. And we have seen what happens if radial nerve injured and what happens if ulnar nerve is injured and median nerve. But here mostly they are sensory symptoms. Coming to the flexor tendons, all of you know that flexor tendons are each finger is supplied with two flexor tendons, flexor digitorum profundus and flexor digitorum superficialis. And flexor digitorum profundus goes up to the base of the distal phalanx and it will flex all the joints. Okay, so that is more important. If you have, I think we already discussed that if you have given a choice to repair when two tendons are cut, you should always choose flexor digitorum profundus because it goes till the base of the distal phalanx. Okay, then ultra sensitive to touch. And these thenar muscles and hypothenar muscles, all of you know, without touching, I think I am doing orthopedic surgery here. Without touching, I think no touch technique. In orthopedic surgery, we follow what is known as no touch technique. Every soft tissue, every dissection which we do, usually we should do with the instrument. We are not supposed to do it with our hand, like most of the general surgeons and gynob surgeons, they routinely do it with their hands, but orthopedic surgeons are not supposed to touch. We should follow what is known as non-touch technique. Even I think here also I should follow non-touch technique. All of you can see the thenar muscles, thumb, at the base of the thumb, and hypothenar muscles opposite near the little finger, and you see the flexor tendon. So you see the transverse carpal ligament or the flexor retinaculum. All of you must have seen it, and during your anatomy days, dissection days and all. It's a very, very important structure. It's in the front of the wrist. And it's like a wristband. It's made up of ligamentous material, and it has several compartments for the passage of tendons, muscles, tendons and vessels and nerves also. So we'll go into that. So this is a schematic representation. What are the structures you are going to see once you open on the palmar aspect of the hand? These are the structures you are going to see. Coming to the close-up, here you can see this transverse carpal ligament, or it's a part of flexor retinaculum. It extends from medial to lateral side, and through which this carpal tunnel is there, and through that carpal tunnel, median nerve traverses. And these are the other nerves which are in close association with that. And this is present on the carpal bones. That's why it's called carpal tunnel. Most of you can make out these carpal bones, and above which that opening you can see that arrow going through and through, like our median nerve. Imagine that is our median nerve going into the hand from the forearm through the wrist. So this is the opening of the carpal tunnel. If the opening becomes narrow, because of so many reasons, we'll go into that a little later. Once that narrowing is there, then there will be compression definitely, which will lead to these symptoms. Here, these are the structures which are arranged in that opening, carpal tunnel opening. And on the top you can see the median nerve, yellow. Usually the nerves are represented in yellow color, arteries in red, and veins in blue. And here the tendons, flexor tendons you can see, and they are ensheathed in a tenosynovium. It's a covering over the tendons, because it provides protection and easy passage. There will be some fluid inside, and which will reduce the friction, and tendon can easily slide in and out through that tenosynovium. And these are the structures which are present beneath the transverse carpal ligament, which I am telling you again and again is a part of flexor retinaculum. You can see the carpal bones at the floor of the carpal tunnel, and that is the arch of the transverse carpal ligament. So this is the cross section of carpal tunnel. You see flexor tendons, you see median nerve. Coming to the pathological part of it, see, it is angry looking, and red indicates anger, and here it is the inflammation. Inflamed tendons and tenosynovium, they occupy more than normal space for them. Once that is there, then the space for the median nerve becomes less and less. Then there will be compression, pressure all around. So it's like an exam going student, pressure from all sides, expectations from the parents and from the friends, and peer pressure and pressure from your side. There is someone residing in all of us. We all know our potential, and we always try to do up to our potential. So that is also a pressure. That's the pressure we are putting on ourselves, and all of you should do that also. And take it in a positive way, so that unless you have that pressure coming from within, you will not be able to do anything. But this is a pressure which is coming from outside. That means the surrounding structures are exerting, and the roof which is there, that carpal ligament which is there, flexor retinaculum, is very tough and unyielding. So it won't yield any space for nerve to be not compressed. So it is from all sides it's being pressurized, and the nerve will show its anger by showing symptoms. And what are the causes of CTS? And it can be divided into work related or medically. Work related means what type of work you are doing, and if your work entails you to put lot of pressure on your wrist and your hand and your tendons, if it is more of a repetitive work, then definitely it will have a deleterious effect, and it may lead to inflammation of the tenosynovium, and it will lead to CTS. If it repeat, it's a part of repetitive stress syndrome. So these software guys and all who will be using the mouse day in and day out, so they are at a higher risk. And high force, whenever you are using a high force through your hand when you are working, then that will have some negative effects. So that energy while dissipating may injure these soft tissues, and once there is injury, then there will be inflammation lurking around. And so whenever there is a infection or injury, inflammation will be there. So once it is inflamed, then definitely you can expect a pressure effects. So CTS is nothing but a pressure effect, so you can have it. And awkward joint posture, this is the commonest actually, because we never bother about our posture. Whatever you are doing, you never bother about your posture. So whenever you are sitting or working on a computer, so you slouch down in a sofa, keeping the laptop on your tummy and doing all sorts of things, playing video games or watching some tic-tac videos or making them. So definitely the joint posture is not right always. So it may lead to increased pressure at this area, and it may cause CTS. And if there is something which you are doing which will produce direct pressure, as it is, these are unyielding substances, and if you put pressure directly on the nerve, definitely you will have these symptoms. And if you are in a profession where there is a lot of vibration, then definitely it will lead to this CTS. So these road cutters, they will be using these pneumatic drills or rig, these people who dig bore wells. Those implants or instruments with which they are working produce a lot of vibration, which will lead to a lot of pressure locally, and it may lead to CTS. And whenever you have, like I said, if you are in a prolonged constrained posture, so if you are watching a movie in Netflix, then that 2 hours or 3 hours, you don't even take breath. So you are completely immersed in the movie, not even moving a single muscle, and just eyes on the screen and brain closed. So those things may produce awkward posture, and it may be one of the reasons for CTS. And medically related, what are the various things which you should know? These fractures. Whenever there is a fracture in the lower end of radius or ulna or any of the carpal bones, and if they are malunited or if the fracture fragments are jetting in and reducing the dimensions of the carpal tunnel, then definitely it will lead to CTS. And arthritis. Most of you know that arthritis is an inflammatory condition of the joint, and any inflammation definitely will lead to CTS because the space is compromised. And diabetes, you guys are lucky that if you don't know anything about the causation of any problem, you can just mention diabetes. When we were medical students, we used to write tuberculosis for everything. Or syphilis. Our seniors used to write syphilis because it can mimic any disease, and any symptom or any clinical condition can occur through syphilis. Then next, tuberculosis. But now it is the diabetes which is ruling the rules. So if you can say, if you don't remember anything, and if you can say diabetes for everything, then you are partly right. So if you want to give some marks, at least say diabetes for everything. Okay. Then obesity, and diabetes, they usually go hand in hand because our dietary habits and our junk food, our Lays chips and kurkures, and what all you eat in and around our college, all of you know that it will definitely add, whether it will add to your stature or not, I don't know, but it will definitely add to your weight. It will add some kgs or pounds to you. So I think most of you guys are missing this uh, weight increasing program because you are not coming to the college and you are missing your knickknacks every day. But I don't think you are entirely off it because you can find some such joints all over the city wherever you are, and I think you are still at it. Okay. Then coming to the other clinical conditions which can occur, acromegaly. All of you know that acromegaly, the dimensions will be increased, and once the bones and all, there will be a bit of more growth. Then the canal is reduced. And in pregnancy, this is the condition which I was referring to earlier, because this is the condition which can be seen only in females. So pregnancy, there will be a generalized inflammation will be there. So all these ligaments, they become a bit loose or inflamed. So it's a nature's way of trying to push the baby out at the time of delivery. So even here there will be some water retention because of that hormonal imbalance and all, which may lead to some inflammation and increase in the size of these tenosynovium and these tendons, and which will lead to pain, CTS. And other culprits, usually fluid retention, as I was telling to you, fluid retention, that may be the reason in pregnancy. And diabetes, our ubiquitous friend, you can put it anywhere and you won't be more often than not right. And sudden weight gain, which all of us will have if you come to college regular basis. And birth control pills, as most of you know that they contain steroids, and steroids hormones, they help us in some ways, and in some ways definitely they have their own side effects, and you should be very wary when you are prescribing one to your patient, or whenever you are trying to use these steroids for any clinical conditions. Be very careful. Coming to what are the symptoms with which the patient comes to you? The main symptom with which the patient comes to you is pain in the wrist and hand. Usually this pain will be very severe in the night times. So whenever the patient is sleeping, why in night times? When we are sleeping, then most of our muscles will be relaxed. Once that is there, all the protective mechanisms which are in place, that means all of us, we wear a mask when we are not this surgical mask which we had to force to wear during this corona time, which most of other guys are not doing, thankfully, outside. That's why they are contributing to the increasing number of corona cases in India, and I think shortly it will be number one in the world, thanks to our people. So the mask I'm talking to is, we want to show to the world that we are very goody, we don't do any wrong or anything like that. But when we come home and when we are yourself, then naturally you take out all those masks, and when you go to bed, you will be yourself. So once that happens, you relax. Along with you, all the muscles relax, all the protective mechanisms which are in the body, they relax, and your wrist will also assume all asymmetrical positions, then maybe there will be some pressure and the patient wakes up with that severe pain in the wrist and hand, because there will be severe pain and severe compression on the median nerve. So that is a pain severe in the night, or the pain, patient complains of pain after work when they are working a repetitive work, especially with the hand and fingers. Then definitely we can think of and the pain which is there in the typical areas, 3.5 fingers, definitely, and in the uh, uh, thenar area, and the numbness and tingling in the fingers, as a finger supplied by the median nerve, and grip is weakened because of the median nerve weakness. And once that sense of touch is deficient or different, then you feel that your hand is swollen, and whenever you want to hold something, your grip is not right. So all these things are because of the sensory aspect of the median nerve which is getting compressed. uh, so this is about the symptoms with which the patient comes to us. And something about the inflammation, as all of you know, that this is the body's response to injury or infection, either it be corona or any other infection or injury. That's what we were discussing in the previous class, all that SIRS, systemic inflammatory response, and compensatory anti-inflammatory response syndrome, CARS. All those things are because of the inflammation. So here what happens is there will be dilatation of the blood vessels and increased temperature at the site. So whenever there is some inflammatory response, as all of you know, that dolor is nothing but increased temperature, and blood vessel dilatation will be there. And there are some stages here: inflammatory, proliferative, and remodeling. So because of all these things, the different cell types will come and occupy that area, producing different aspects of the symptomatology. Coming to the structure of a tendon, as we have already seen, it consists of several fibers, and those fibers are enclosed in sheath, and ultimately the tendon is tenosynovium covers it, and it's for protection, for its optimum function and protection. And whenever it is moving the tendon, there should not be any friction, or there should not be any block during its path. So there should not be any speed breakers. Whenever your tendon is working, then only your fingers can work smoothly, whether it is flexion or extension, and you can go about doing your things. But here what happens in CTS, there will be inflammation of the tendon sheath, and the dimensions increase and they compress the median nerve. So how do you diagnose? Once the patient comes to you and tells you about this, then definitely you can have a suspicion that it could be a carpal tunnel syndrome. Then you should, during the history, you should ask them what is the job. You should never make an impression, give an impression that you are asking about their job to how much can you bill after the consultation. They should not get the idea that if they say they are working in TCS, you can increase your consultation fee. So that's not the thing. We should know what type of job they are doing. So if they are doing as I said, a software related to software work, which entails them to be doing work on computers with the mouse and all, or any job where they are using some vibration, where workplace has lot of vibration, or their instruments or implants with which they are working cause lot of vibration. All these things will be known if you take the job history, and you should ask them about the symptoms. Then the patient will definitely tell you about the time of that pain, when they get the pain, and where all is the numbness and altered sensation. Everything the patient will point it out. And then you should ask about various medical conditions, starting from do you have any diabetes, or is the patient pregnant, so many things, or is she on any medication, steroids, birth control pills, or so many things, hypothyroidism. All these things can cause this CTS. So you should during your medical history only try to elicit as much information as possible. I always tell my students that history is very, very important. Why? Because history is his story. So you should, all of us are fond of stories. So, and we make up a lot of stories whenever you are late to the class or whenever you are late at home. If you come home after curfew hours, definitely you invent a new story. So whenever we were late during our anatomy days, whenever we were late, by dot of 8 we should be in our dissection halls. If you are late at least by 5 minutes, then one of my associate professors used to ask me, tell me a new reason every time you come. If I like the reason, then I will allow you. So we used to use our imagination to invent a new story every time. That's how you can improve your imagination as well. So medical history is very very important, because you can hear the story of the patient. Patient can be his or her. There is no gender discrimination here, but history means story. Okay, coming to the physical examination, Tinel sign, all of you know that Tinel sign will be present whenever there is a nerve injury. It could be a axontomesis or a neurotomesis, and Tinel sign is not seen in neuroproxia. All of you know that tapping a nerve from distal to proximal will elicit a funny response, funny site of symptom. Patient will tell you feeling at the site of regeneration of the nerve, and usually it starts proximally and goes on distally till the whole nerve is regenerated. So that is Tinel sign, all of you know. And Phalen's test is whenever you do some movements when this nerve is compressed, then definitely the patient symptoms will be reproduced. That's called Phelan test. You ask the patient to put the wrist in different aspects. That means nerve, wherever the nerve is compressed by the movement of the wrist, by the positions of the wrist, then definitely it will reproduce the symptoms which the patient is getting. So if you can do that, and if you can demonstrate those symptoms with your Phalen's test, that means compression of the median nerve because of the position of the wrist, then definitely your diagnosis is more or less clinched. Then coming to the muscle strength, you can test the thenar muscles and their actions, and you can see whether the muscles are normal tone, strength is also normal, or if there is any weakness in them. If there is weakness, obviously that is the median nerve which is at is the main culprit, and this could be a part of CTS. Apart from your clinical examination, you can do some laboratory tests to make your diagnosis, strengthen your diagnosis by means of X-ray, MRI, and electromyography and nerve conduction studies. So all these things which I have already seen, X-ray, you know, if there is any fracture or if there is any malunion or if there is any alteration in the lie of the bones, any problem is there, then definitely it will be easily seen in the radiograph. And all of you know that these radiographs should be in two planes, AP and lateral. And if sometimes if you need it, then you can have some stress films or flexion and extension views which will aid your diagnosis. And MRI definitely will show you if there is any compression of the nerve here. Structurally you can show, and you can see the dimensions of the carpal tunnel, and you can see all the tendons and their sheaths, and if there is some inflammation or if there is some inflammatory fluid in the tendon sheath, that can be visualized in an MRI. And MRI is the definitive diagnosis after you have your clinical examination. Just like that, as soon as a patient comes to you and tells you that they have some wrist pain and pain in the fingers, just don't shunt them off to MRI. Don't do it. Do the clinical examination first and have an idea. Then to clinch your diagnosis only, you should send them to laboratory diagnosis tests. Don't do these tests first, then come to a diagnosis without doing your physical examination. So physical examination is the ultimate thing, and if you do a proper clinical examination, then you can know which investigations to order. Investigations cannot tell you the diagnosis by themselves. Okay, so physical examination first and the laboratory test will aid your help you in coming to a proper diagnosis. And electromyography, all of you know, we have discussed this, and it will show whether the nerve which supplies those muscles, whether it is working or not. And nerve conduction will show the speed with which an impulse is traveling in that nerve, and it will show whether there is a block somewhere, or if the nerve is in continuity or not. So all these things can be clinically and objectively assessed by means of electromyography and nerve conduction. So the other things, it's only a subjective. In MRI and X-ray, it's a subjective thing. You can interpret it. If you know how to do it, then you can interpret it properly, and even then it is a shadow in shadow. It's a subjective one, but objectively you need to have these two, electromyography and nerve conduction. You can show that this nerve conduction velocity has come down because of this compression. Before the block and after the block, there will be some difference in the conduction of the nerve impulse. So if that velocity is different into, usually it should not be, because the nerve is a continuous structure. It's like a electricity passing through a wire. It should be a continuous process. But here, because of the block, there is different values before and after the block. So if some such sort of thing is there, then definitely the block is, you can objectively say that there is something wrong here. So these two are a must before you put your knife to relieve these symptoms. What are these MRI and X-rays show? X-rays, you check for arthritis or fractured bones, and not useful for detecting CTS. I don't accept this statement, but I just tell you because most of the times, without taking an X-ray, people jump to for MRI. There are so many reasons for that. We should not discuss these things in public class. But always before sending for an MRI, you should take an X-ray. Okay, the CTS, swelling and all, severity, not used routinely because it may cost a bomb. Then electromyography, all of you know, objective study, and it will definitely confirm. This is also an entrance bit, so they can say that the test to diagnose CTS, then symptomatology, all these things they can give, MRI, X-ray, patient symptoms, and EMG. So all of you should tick EMG because this is an objective assessment. EMG and nerve conduction study. Okay. A nerve conduction study here, it can detect up to 84% and it can eliminate about 95%. Oh, what more can you ask? So this is how they do it, nerve conduction study, and they put the electrodes and study the velocity before and after. Coming to the treatment, see, once you have made your diagnosis and you have done these tests, and nerve conduction tests have shown that nerve conduction velocity has lessened after the block, and electromyography also indicated that there is something wrong with the nerve. Then coming to conservative, always start the conservative for everything. Usually rest, ice, heat. Usually these things will definitely reduce the inflammation. Once the inflammation of the tenosynovium comes down, then the problem will go away on its own. If it is a mild one and which is caused because of the recurrent usage, then definitely it will come down. Otherwise, you may need to use a brace like this that will give rest to that wrist and the structures within. If you have a brace like that, I don't think you can start working vigorously like before, because that will immobilize the joint and it will keep on reminding you that all is not well with your wrist. So go slow. So that brace can work in both the ways. And physical therapy like ultrasound therapy, which will reduce the inflammation. What all you do is to reduce the inflammation. Once the inflammation of the tenosynovium comes down, then there will be no pressure on the median nerve and the symptoms will definitely improve. And for the pain relief, you can use NSAIDs, and all of you know that COX-1, COX-2 or the specific COX-2 inhibitor should be used if they are using for longer time. But here you can start with a simple plain paracetamol, friendly neighborhood paracetamol can do the trick for you. And steroids are indiscriminately used by most practitioners, which has to be condemned, because the role of steroids in these conditions is very, very limited. But unfortunately, it's only the orthopedic surgeons who are more worried about steroids than any other branch of medical specialists or surgical specialists, because ultimately at the end of the day, if you go on pumping steroids into somebody, we are the ones who has to get the baby. That means the bones become very, very weak, and the bones become very, very, very much osteoporotic, and if you just touch it, and the bone will break, and if there are any fractures, then they will be referred to us, and by the time they come to us with severe osteoporosis, and to treat those patients, I think it's next to impossible. And I still remember one patient when I was in Gandhi Hospital. She was a vegetable seller, and to my misfortune, she was in Monda market, where whenever I used to go and buy vegetables, because buying vegetables is a very, very relaxing activity. Just believe me. If you don't believe me, just try doing it whenever you are very tense, or just before exams or something, or if you are worried about the IPL match which is coming next. Then if you are very much worried, then go and buy some groceries or best vegetables. If you go and buy vegetables, I think definitely you feel very, very relaxed. So I used to do that. So see, I used to, instead of roaming around, I used to go and buy at one place only, so that every day, if you are get cheated by one person, at least on some days they will take pity on you, and they may be nice with you. So if you go on buying different things with different people, everybody routinely cheats you, and every day it will be cheating for you. So if you go for like that on a regular basis, and that lady had a fracture humerus, and naturally she came to me for treatment. So I posted her for open reduction and internal fixation, and yeah, as the luck have it, I put my knife and just cut the skin, and I was just separating the muscle with my artery forceps. Then artery forceps just went into the humerus. So usually artery forceps, it doesn't go into a bone just like that. So it was just like cutting a butter with a knife. Once you put a knife there, just it goes into the butter like that. Then I was stunned. I have never seen a bone like that. So how to put a plate on that? If you put your bone holders and hold the bone, they will crumple. Then I had to do a non-touch technique. I opened away from it. It's a like a closed technique, nailing. So I was very lucky to come out unscathed on that day, and predictably that lady went into non-union. But she was very happy with the nail inside. She could work like before, and there was no. And every day when every time when I go to that Monda market to buy my vegetables, I had that. Funny feeling that I couldn't do what I should have done to her in a proper way. I should have assessed her preoperatively, and but anyway, I had done what I could, and she's improved. I think she was working functionally normal. Thank God. I thought then, yes, there is somebody up there who is watching, and I was ball bach gaya. So these are the orthopedic surgeons who usually will bear the brunt of this osteoporosis. So all of you in other medical specialties, you go on pumping steroids, and at the end of the day, we are the ones, unfortunate ones, who had to hold the baby. Okay, so be careful whenever you are prescribing steroids or using steroids. The other modality of treatments, as surgeons, we will wait for an opportunity to use our knife. And as of most of you know that now endoscopy is ruling all branches of surgery. Nowadays, no surgeon, general surgeon, is doing any laparotomy, open laparotomy. All of them are going for this endoscopic surgery. If you have a appendix, remove the appendix by endoscope. If you have a gallbladder stone, endoscopy. So it has come to such a stage that everything endoscopy. So if it is lab chole, first if lab chole fails, then paid chole. That's the saying in gen surgery. First lab chole, and if you fail to get your gallbladder out, then the next option or any complication, paid chole. Anyway, you can open the abdomen. So that's the mantra nowadays. Endoscopy first, then open surgery last. Then even here we can put an endoscope into that carpal tunnel, and we can release that ligament endoscopically. So you need not have a cumbersome surgical procedure to do this CTS, relieve this CTS anymore. And apart from endoscopy, we can do nowadays everything in mini. The dress is mini and mini or micro or whatever, and even the incisions have become a mini. So previously, when I was a student, there was a dictum that the big surgeons will give big incisions. So the bigger the incision, the more suturing it needs, and the more the suture, the more the money they can take from the patients. Usually the patients are convinced that if you put 50 stitches, you can take 50,000. But if I do a surgery with a one or two stitches, and if I say my fee is 50,000, they will say, what doctor, you didn't even put more than two sutures and the surgery is so simple and you are asking for 50,000. So they don't know about the complexity of the surgery. They see only the external appearances. So all of us know that external appearances count. So even in surgery, even in our field, external appearances count. That's why previously they used to do bigger incisions, but nowadays endoscopy has taken its place. If you say that I don't open, I'll just put the scope inside, I'll do it, then they are ready to shell out any amount. So endoscopy, or you can do mini open release. Otherwise, like everywhere else, you can distend the tunnel by means of percutaneous balloon. You can also do this plasty, like you do for these coronary arteries, stents and all coronary plasty. They are keeping it inflated and keeping it in place to increase the blood supply. So similar things can be tried. Otherwise, our good old surgical method, open and cut the offending part. Here you just open, you can see in the inlet, this is the incision we give. I'm sorry. Yeah, inside inlet you can see the incision, oval incision, and inside you are cutting that flexor retinaculum or transverse carpal ligament. Once you cut, then the tension within that canal is relieved. So there won't be any pressure over the median nerve. So by cutting, you are not doing any great damage actually, because all those ligaments are tethered to the soft tissues underneath. So even with that, even without that flexor retinaculum to guard them there may not be so much of bowstring effect or anything. Functional ability is not so much compromised, but symptomatically patient will be immediately uh, he can get better. So this is one of those surgeries where you can promise miracles. If your diagnosis is correct, if the treatment is correct, you can definitely promise them miracles. So before surgery and after surgery, patient will be uh, clearly can experience that relief, absolute pain relief. Patient will be euphoric. At that time, you can hand over your bill. Okay, so this is one surgery which no surgeon should miss. So if you are a surgeon, definitely if you can do these surgeries, you feel good that yes, you will definitely have that job satisfaction, the so-called job satisfaction. If you operate, see, this is not a difficult surgery, but you should know what to cut. If you cut the median nerve, then gone. So don't cut a median nerve. So cut the flexor retinaculum or transverse carpal ligament, and the patient will be happy, and you in turn will be happy if you are doing it in a private setup. So endoscopy. Here what they do is they pass the endoscope like this, You can see this steel one. Can you? I Yeah, this is the sheath of the endoscope. So this goes inside and slowly from there you start cutting. Once you do that, definitely the pressure is relieved. So this red, the yellow is a median nerve, and that angry looking median nerve is because of the inflammation. And once you cut this and relieve the, you open the top. It's like traveling in a open top car. So the air coming and touching your face and rustling your hair, that's a feeling as if you feel you are on the top of the world. So similarly, once you take out that pressure, then the top is open, then patient will have that same feeling, and that's the time you can give the bill. Coming to alternate therapy, so you need to reduce this inflammation, but you can try these alternative treatments, but I don't know how far they can help you, because I don't do these chiropractic procedures or acupuncture and electromagnetic. You tie a magnet there, what happens? It will lead to more pain, that's what I think. But this is to complete, so alternate therapies are useless, that's my verdict. And I definitely give conservative management, and if nothing happens, then definitely a small surgery is all that is needed to relieve the pain. If possible, maybe a mini open surgery, or if you have that facility, endoscopic. If the patient wants it, scarless surgery. And nowadays everybody wants to have this aesthetic surgery, so you can have that endoscope and be done with it. So this is all about carpal tunnel syndrome, which is very common nowadays. And I think all of you have an idea about this. I need not say go home, because you are at home, and read about this. Then definitely we can have a better idea. And if you have still any queries, you all know, you can always reach me. You have my number in previous, I think, presentations it was given, and you can always leave a message so that I can try to confuse you further. Okay, bye.